So they can lead to various skin issues, and let's discuss a few. So the most common one is acne. It is usually severe and persistent, located on the face, chest, and back. But something that is very classical for hormonal acne or acne associated with PCOS or other hormone issues is that it is located on the lower part of the face. It is concentrated more on the lower part of the face, and you can see different grades of acne, but concentrated to the lower part. It's a classical feature of hormonal acne. Other things, other issues that can be seen are oily skin and seborrhea. A lot of the PCOS patients, they complain of seborrheic hepatitis because of excessive sebum production. Then comes hirsutism, excessive hair growth in unwanted areas in the male pattern areas, thick, coarse hair. Then there are something known as acanthosis nigricans and acropodons or skin tags. These two features, they are they're very specific for insulin resistance. If some patient has these two features, then it gives us an idea that, all right, they might be having some form of insulin resistance because these are very classical for that. They are the skin markers of insulin resistance. Acanthosis nigricans, they're dark velvety patches present on the neck, armpits, and groin. While skin tags, they're small outgrowths of skin, they're benign, and they're present in the skin folds. So these are all the manifestations in PCOS taken from this article: acne, hirsutism, seborrhea, androgenetic alopecia, acanthosis nigricans, and acropodons. The most common ones are acne and hirsutism. So what is causing all this? Hormonal imbalances. There is increased androgen. I will be explaining in a pathway shortly. So these increased androgens, they stimulate sebum production. They stimulate hair growth. The insulin resistance further exaggerates this androgen production and in turn leads to increased sebum production, hyperkeratinization, and skin inflammation. There have been a lot of studies where genetic predisposition has been recorded. There are newer studies that have isolated certain gene loci, certain variable tandem repeats, VNRT3, where they've seen that those individuals who have these gene loci are more susceptible to PCOS, more susceptible to insulin resistance. So various hormones, they play a role in all these features. Hirsutism, mostly the hyperinsulinemia, the testosterone, and the DHEAS, these are implicated more. In acne, the insulin levels, if they're elevated, again, the testosterone, the DHEAS, these are majorly implicated. Like I explained before, acanthosis and acropodons, you see more of insulin resistance in these patients. Now coming to acne, it is an inflammatory process and many factors trigger it, whether it's hormones or there are other lifestyle factors like diet and exercise, environmental factors. A lot of cosmetics people apply, and of course the genetic predisposition. So this is the basic anatomy of the skin, where this is the pilosebaceous unit, that is the hair follicle with the sebum gland. So all these trigger factors like hormones, diet, cosmetics, environmental bacteria, and stress, smoking, all of them together, they exaggerate acne. Somebody who's having PCOS, obviously hormones is the main culprit, but the other factors do exaggerate the skin inflammation. So in acne, you will see inflammation, hyperkeratinization, increased sebum production, along with accumulation of propionobacterium, now known as Cutribacterium. So this pathway, in short, I'll just explain about this, that the lower part, you see that when there is excess androgens, excess of bioavailable testosterone, the 5-alpha reductase. And this
I request everybody to please turn off the mic.
Stimulate the dihydrotestosterone. Now, this DHT will act on the pilosebaceous unit. On the fundibulum part of that unit, it will cause hyperkeratinization. There will be accumulation of dead skin. And on the sebaceous gland, it will cause hyperexcretion of your sebum. So these two together, they will lead to the non-inflammatory lesions of acne. That is the comedones. Now, when you add the Cutribacterium P. acnes proliferation to it, and which causes more inflammation, you will get the inflammatory lesions. Now, the hyperinsulinemia, if there is a high glycemic load in the diet, it will always stimulate the insulin-like growth factor 1 and insulin. These two together will stimulate the androgen receptor activation, will increase the androgen load, and will cause, again, keratinocyte proliferation and sebaceous lipogenesis. So this diagram in short explains about what I was talking about the lesions. So initially you will see accumulation of the sebum and the dead skin in the pilosebaceous unit. Now these two, it can be either closed or it can be open. Now when it is open, it gets oxidized and it looks black. That is why we have the black heads and the white heads, or the closed comedons and the open comedons. Now this, when further there is proliferation of the bacteria, there is all the inflammatory cytokines, interleukin-1, toll-like receptor 2 acting, and other peptides they act, then it leads to the inflammatory papule or the pustule. Now this further, when it progresses, it forms the nodule or the cyst. So this gives you a rough idea about the grading of acne. There is no global consensus about the grading of acne or the stages of acne, but this is a rough idea that you can use clinically. So grade 1, or mild acne, in which you will see only comedons and occasional papules. Grade 2, or mild to moderate acne, you will see comedons, papules, the red lesions, and few pustules. Grade 3, you will see lots of papules, lots of pustules with few nodules and few abscesses forming. Grade 4, which is absolutely severe, in that you will see lots of cysts, lots of nodules, lots of pus and pustules coming out, and there will be widespread scarring. So these photos, they give a general idea. So the first one is showing mild to moderate acne, where there is open and closed comedons and you have few papules. This is on the left side top. Then on the right side top, you're seeing this one here. You're seeing acne, which is moderate acne, where you have papules, couple of pustules, maybe 1 or 2 nodules. So this third picture in the left bottom here, this is what I was talking about, the classical lower predisposition of hormonal acne. And this here is showing you nodulocystic severe acne with lots of nodules that are oozing pus. So coming to the treatment, when it comes to adolescents, they can present with mild acne. In case of PCOS, they can present with severe acne as well. It varies from patient to patient. In case of mild acne, mostly topical agents, they are enough. You can either give benzoyl peroxide or topical retinoid. This can either be given singly or you can combine this with a topical antibiotic. Now, when the acne is more mild to moderate, there are more papules, pustules, you can add a oral antibiotic to it. Usually the preferred oral antibiotics are either tetracycline, most commonly doxycycline, or you can give azithromycin or erythromycin. These are the most commonly used antibiotics. The reason being that besides, it's not the antibiotic action that we need, it is the anti-inflammatory action. That is why the dosing for acne is not your common antibiotic dosing. It is less than that. For doxycycline, the technical anti-inflammatory dose is 40 milligram, but that is not commonly available in India. So even 100 milligram given once daily is more than enough in case of acne. For azithromycin, we give pulse dosing. Instead of daily dosing, we give it 3 times in a week. You can give the 250 milligram tablet, or in case of severe acne, we do tend to increase the dose, but again, it is given as pulse therapy because we want the anti-inflammatory action. We do not want the antibiotic action. So the dose varies in case of acne. When there is moderate to severe acne, it is always best advised that a multidisciplinary approach is taken and a dermatologist prescribes retinoids, because retinoids, they do have a lot of baggage attached to them. The patients need to be counseled about oral contraceptive, even if they're adolescents and the worry of conception and use of contraception is not that evident. Even then, they have to be counseled. It is obviously a must in case of females of childbearing age, but in adolescents, at least an awareness has to be given. In severe acne, usually oral isotretinoin is given along with other agents. It's a combined therapy. Usually one single therapy is not that effective. A combination therapy is always better. Besides the medication therapy, there are a lot of other dermatological procedures like peels and carbon facial and other things that can be done for the cosmetic purpose, because when you have so much acne, it will lead to scarring. It will cause some form of mental issue or psychological issue in the adolescent, especially in the adolescent group. So that also needs to be addressed, and obviously getting a dermatological opinion will help in such cases. But coming to the hormonal part of treating acne, just plain anti-acne treatment is not enough. If somebody has PCOS and they're presenting to you with acne, if they already have history of PCOS, I'm taking a case scenario where they already have history of PCOS, they have taken oral contraceptives and they're presenting to you. Even then, there are times when patients will come to you when they're not for us dermatologists, where they've not consulted a gynae. They're only coming to us for acne. So in those cases also, I always prefer that you take an opinion from a gynecologist as well, because a lot of time oral contraceptives need to be given. My personal take is that you consult a gynecologist. If they suggest that you need oral contraceptives, you take those. From my side, I will only treat the acne. So the combined approach, the multidisciplinary approach, has a much better result as opposed to just giving on our own. In case of hormonal acne, along with isotretinoin, a lot of times we have to give oral contraceptives. In certain individuals, anti-androgens in the form of spironolactone also need to be given. There are a couple of studies where low-dose spironolactone has been given and it has been quite effective as well. So, like I was talking, the psychological impact, like ma'am was mentioning, the body image issue. That if your acne is healed, even if your PCOS is in control now, the acne scarring really disfigures the face and it has a huge impact on the psychosocial well-being of the patient. So obviously in this case, it is best to refer to a dermatologist. I will not be going into the detail about the treatment because it's mostly dermatological procedures. No medicine or cream gives you any form of substantial improvement in scarring. Retinoids, yes, they improve the scarring, but only till a very small amount. You will not see visible results if you want improvement in your acne scarring. For that, one needs to get procedures done. So it's best to take a specialist consultation with a dermatologist. Now coming to hirsutism, there's unwanted excess growth of terminal thick coarse hair resembling the male pattern. And this obviously happens because of increased androgen levels and susceptibility in PCOS. There are a lot of causes of hirsutism. We're just sticking to PCOS right now. So why this happens? Why are the androgens causing hair growth? So they lengthen the anagen, the growth phase of the hair. They will increase the hair follicle size. They will increase the hair follicle diameter, and they will be increasing the sebum production. So you have thick, coarse hair. So this is the Ferriman-Galloway scoring system. This can be done in the clinical setup, but what happens is when you're giving treatment for hirsutism, even if the patient has a lower score, even then the treatment will be the same, because even if the female has 10-15 hairs here, even if she doesn't have a full-on beard, it is still going to affect her. It is still going to be a cosmetic issue. So this helps explain to the patient about the severity. This helps us assess the severity. But in the long term, the treatment will have to be given, even if the score is less. So obviously the underlying cause has to be addressed. These days, the most common concept is, okay, you have hirsutism, get laser done. what we need to understand is that yes, the hair that has come, it might reduce with your medical therapy, but it will not totally go away. For that, you need to get laser hair reduction done. But laser hair reduction is a long process. It takes time, and it will only be effective if your baseline hormones are under control. Either they have already been in control for some time, or you're taking active treatment for that. Only then there is a point of getting laser reduction done. Otherwise, you get laser done, you see a reduction in the hair, but because your hormones are not under control or you're still having some form of hyperandrogenism, the hair will come back. So the hormones have to be normalized for the laser to be effective. It is not that you have to wait for the hormones to normalize and then take treatment. This can go on side by side, but that aspect has to be addressed. Like ma'am was saying, laser hair reduction, yes, it can be costly. It takes time. The number of sessions, a lot of people have this question in their head, how many times will we have to get laser done for it to be effective? No one can give you a single number. It varies from person to person. It varies on your physiological attributes, your hormone disbalance, how often are you taking the laser treatment, and how correctly was it done. So for the correctly part, it is always advisable that you get laser reduction done from a qualified dermatologist, as these days it is available everywhere, and not all they're not all dermatologists who are using the laser hair reduction devices. As far as electrolysis is concerned, it is still done, but it is mostly done when we have white hairs, because laser does not work on white hair. We don't do it in practice for hirsutism in general because it causes scarring, and you want a clean result. That scarring will persist. So people don't prefer to go for electrolysis. Laser hair reduction has much better results as opposed to electrolysis. Lifestyle changes, like I said, the other part of hirsutism, the hormonal part, the causative part, that has to be addressed. Weight loss and dietary modifications, all these need to be done. Psychological support is very essential. Psychological support has to be given, because having men like thick hair on your face for a girl, especially an adolescent girl, is very, very difficult. It leads to a lot of issues, and that has to be taken care of. Like ma'am said, that sometimes you need to counsel the patient like a mother. So coming next to canthosis nigricans, this is something that you'll see, there is darkening of the skin at the back of the neck, in the underarms, in the private area. This is classically seen in patients who have insulin resistance. This is a cutaneous marker for insulin resistance. So the treatment, again, you have to address the underlying cause. Even if the patient undergoes various treatments, whether it is topical treatments or dermatological procedures, unless and until the patient gets their weight under control, their insulin resistance reduces, they will not see a major improvement in these symptoms. Topical therapies like retinoids, keratolytics, urea-based creams, laser therapy, these all can be done to reduce the appearance, but that improvement will be just temporary. If you want to have good improvement, then the patient needs to have lifestyle modifications where weight loss and dietary changes, they have to be included. Coming next to acrocodones or skin tags, these are benign growths. They don't disappear on their own. There is no medication for this. You can just get them removed either by electrocautery or by laser assisted removal. They don't come back on the place they were there, but if your insulin resistance continues, they will develop in new places. Another thing that patients with PCOS suffer even in adolescence is hair loss. You will not see this severe form of hair loss. This is just the grading, known as the Sinclair grading for female pattern hair loss. But the grade 1 and 2 has been seen in adolescents, especially when there is history of PCOS all through adolescence. Then yes, grade 2 also can be seen. So for female pattern hair loss, the treatment is quite limited. The hormone control obviously has to be there. Along with that, minoxidil therapy can be given. We can start with 2% and go up to 5%. These days, even oral minoxidil 2.5 milligram is also given. The other therapies that help reduce the progression or slow down the progression of female pattern hair loss is platelet-rich plasma therapy, where the patient's own blood is taken, the platelets are separated, centrifuged, and that is injected back into the scalp. So that helps with the hair growth, that helps with turning the fine hairs that have become the thick hair of our scalp that has become thin because of the androgen and 5-DHT effect. They are given stimulus to grow with platelet-rich plasma therapy. Now, if somebody is not very willing for blood treatments, then we have something known as QR678. These are biomimetic peptides. Again, these are injected into the scalp and these help in hair growth. So to summarize, oral contraceptives will obviously have to be given to regulate the hormones. Anti-androgens are a lot of times given. Metformin for insulin resistance can be given. Usually isotretinoin is given since the acne is usually in a moderate grading. Lifestyle changes with low GI diet and regular exercise, weight management. This is an essential part. US is not just one-time thing. It's a lifestyle. You have to address it on a daily basis. Then dermatological treatments for acne skin and skincare regimens good to your skin can also obviously be taken by the patients. So that's all about me. Combination of medical treatment, lifestyle changes, and skincare will obviously improve the skin challenges that are seen in US. That's all from my side. I'm Dr. AAkriti Chawla. I'm practicing at Reneha Skin Clinic in Noida, Sector 31. And for any more details, you can contact me. Thank you.